My name is Alexander Dohanik. As Carl said, I'm an MSK radiologist currently working out in the community in Red Deer, Alberta. So today I'm just going to share a few things that I wish I knew in residency and fellowship. Kind of, a bit of a look back on my last 6 months in my transition to becoming an attending and things that I would have wished I would have picked up a bit sooner. So a little bit of an outline for my portion of this talk. I'm just going to talk a little bit about my residency and fellowship experiences and what I wish I knew at both levels of training about how to succeed once staff. And then I'll, end it off with some musings on the softer points of securing the career that you want. So my background, I'm originally from Calgary, Alberta. I did my residency out at Dalhousie in Halifax, Nova Scotia. I finished a fellowship in musculoskeletal imaging from the University of Alberta with Suki Dillon, who just recently spoke. And I'm currently working as a community radiologist in Red Deer, Alberta. So kind of both, wearing the MSK hat as well as wearing the general radiologist hat out here. So my residency and fellowship. So my residency experience and my approach to residency changed over the years. It's kind of a bimodal approach to reading after work. So I started off very strong and hitting the books very hard as a PGY2, and then kind of petered out. I did my residency during COVID times, and you kind of, reach a certain level of fatigue and then picked it back up again towards the end of residency when the Royal College exam was looming. Had a lot of mentorship with attendings. One of the things that I really benefited from in my residency was kind of a low attending to resident ratio. So I was able to get to know quite a few of the attendings that I worked with and be able to kind of pick their brains and utilize them for mentorship. And co-residents also formed a big part of my support system at that point in time. And these are actually the guys that I graduated with here. So things that I wish I knew more in residency. So I guess when I was presented with this topic, it's a very broad thing, and I could talk for hours on this topic, especially looking in retrospect. But I guess the basic things that I would emphasize is consistency with reading across the years. Try to, try to set up a good habit and try to maintain a certain level of reading. Don't, overexhaust yourself and, continue to read around your cases, but also focus more on anatomy, which specifically pertains to MSK, because there's so much nuanced anatomy. And by the time I reached fellowship, I thought I had a decent grip, but then I quickly realized that I could have had a much better grip coming into that sort of thing. And even as an attending nowadays, I find that the anatomy, especially when I have to go into nitty-gritty stuff, certain like neuronal anatomy, neuro MSK, that sort of stuff, that's where I kind of grind to a halt. And have to stop and look up things. And, I kind of wish that I'm like, okay, I wish I knew my brachial plexus a little bit better. I wish I knew this and that. So that's one of the things that I kind of reflect back on and say, hey, I wish I would have done this more in residency. And ultimately, again, residency is, both for learning, but also for networking. Getting to know people both inside your institution and outside of your institution, through things like these virtual trainee events, other conferences, and the like. And I wish I would have networked a bit more. I think, at the end of the day, medicine is a job just like any other. Sometimes it's not what you know, it's who you know, in order to be able to get the type of job that you want at the end of the day. So don't be afraid to put yourself out there, to have those conversations, to make introductions, and actually try to talk with the people that you may want to work with in the future. I also wish I would have explored different work settings a little bit more as well. And sometimes this is a bit program dependent. I know that we were very lucky out at Dalhousie in order to kind of facilitate this. We had some community radiology rotations, as well as we had the ability to do locums out in the community as well, to kind of be able to see the differences between academic and community settings, because ultimately at the end of the day, that's going to set you up for success, is to try to figure out where exactly you think you're going to fit in and where you'd be the most, fulfilled from a radiology standpoint. And, at the end of the day, residency is 5 years. It's a grind. It's a hard 5 years, but sometimes it's nice to stop and actually just enjoy the time a bit more. So don't be afraid to stop and take a little bit of a breather and, go out with your co-residents, go try to, explore the city that you're in and that sort of thing as well. Sometimes you just get so caught up on the work that you kind of lose the life, in the perspective. So my fellowship, moving on to the next phase of my training, was a mixture of diagnostic and image-guided minor procedural work, things like joint injections, bone biopsies, nerve root injections, and the like. Fellowship in contrast to residency was mostly on the job learning for me, with reading being more supplementary at this point. Like Suki was mentioning, by the time you reach fellowship, you should have a pretty good basis for whatever you're going to do because, conceivably you've passed your Royal College exam and done all that studying as part of that. So this at this point in time is kind of more picking up certain skills and certain techniques. And when I was going through my fellowship decision, I chose a Canadian fellowship purposefully, and I'll kind of talk about that in a moment here. So most fellowships are 1 year, except for the neuroradiology residency. So make the most of your time. Looking back, one of the things that I wish that I would have done a little bit more is advocate for my own needs as a fellow. So identifying holes in your knowledge and skills and then advocating to fill them as part of that. Because fellowship ultimately is for you first and foremost. It's for your own professional development. And sometimes you get stuck in the minutia of, I need to do these rounds and I need to do this little, bit of responsibility and that little bit of responsibility. And you forget why you've actually shown up there, which is to pick up certain skills that are going to be able to make you the best radiologist that you can be in the job that you're gonna be in at the end of the day. Absorb all you can from your mentors, pick their brain, see how they tick, see how they approach these problems, and see what you can apply to your own kind of professional development as well. And then practice multiple approaches to the same task and problem. Specifically in MSK fellowships, without that minor procedural work, you'll see a bit of variability of how people will approach the exact same task. And sometimes certain things just jive better with the way that you work and other things just don't work as well. And so practicing multiple approaches, and once you are out in the community and you're kind of the end line when you face a tough task, at least having a few different ways to troubleshoot is a helpful way to go about it. So I'm just going to briefly talk about some notes on selecting a fellowship. And ultimately, at the end of the day, I think you should select your fellowship based off of the job that you want. So you should be asking yourself these questions, do I need to be in a particular location? And if so, what does that location need? Do I want a big research component? Do I want more procedural work or less procedural work? Do I want to work in an academic center or a community center? And once you kind of answer those questions for yourself, and there's no right or wrong answer, obviously, once you're in those fellowship interviews, ask your questions to the interviewer and make sure that you're going to obtain the skills that you need in order to succeed in that particular job. Because not all fellowships provide the same skills or experiences. And I've seen a few different instances where people have gone, to certain fellowships and found themselves locked out of other jobs just because they did not develop the type of skills that they need in that fellowship to make them competitive for the role that they wanted. And then just be mindful of chasing prestige for the sake of chasing prestige. Sometimes, we kind of get caught up in, oh, what will the name behind the fellowship provide me? What doors will that open? And sometimes it does open doors, especially if you're more in the research kind of geared side of things and want to tailor your practice that way. But sometimes just because there's a big name behind it doesn't mean that it's necessarily better. So I'm just going to end off here with some musings on the softer points of a career and transitions. So in my first year of practice, it's another transition, just like anything, just like when you went from medical school to residency, residency to fellowship, fellowship to staffhood is its own transition. And it comes with its own set of difficulties, as I have intimately, experienced over the last few months. And transitions in medicine are ultimately difficult, so try to make it as easy as you can on yourself. Set up your support systems both inside and outside of work. One of the reasons why I picked the practice that I did was because I knew that I was going to be working with great colleagues out here, and that, as a first year attending, there's still going to be things that I'm going to need to bounce ideas off of people, and I'll need that for the entirety of my career. But having that kind of strong kind of support network at work will really help to be able to ease some of the bumps in the transition as well. And tailor your practice. One of the mentors that I had in residency gave me a piece of advice that at first I was like, oh, I can do that. She said, don't always say yes to everything. I know a lot of us tend to be very people pleasing, very, gung ho in, yes, I can do that for you, or I can learn that skill, or I can do that. And sometimes you need to be able to set your boundaries and say, hey, like, for example, I said I don't read prostate MRIs and kind of took that out of my practice just to, kind of tailor things down to a level that is a bit more suitable for what I wanted out of my role. And a lot of jobs, assuming that you're making very reasonable boundaries are quite accommodating of that. And also check in with your mentors. Even after residency is done, I've still chatted with some of the attendings that I worked with and picked their brains on certain things and thanked them for certain lessons that they taught me throughout residency. And, there's still plenty to be gleaned from that network that you created within residency to help ease the transition. But ultimately, at the end of the day, I think the most important thing that I've learned in the first year of my practice is to keep humble and keep learning. It's it's a practice of medicine. You're never going to be perfect at it, and you're never going to know everything. So just keep trying to better yourself, keep trying to fill in those gaps, keep trying to learn from both reading, but also from your own colleagues, because there's so much to know and so many people to help you out along the way.
Hey guys, I'm Bill Wong. I'm one of the musculoskeletal radiology fellows at University of Southern California. I'm going to be talking about how to get a job, some practical strategies. I am an incoming staff at Royal Columbian Hospital, which is a community practice in New Westminster, about 30 minutes from Vancouver. So we'll also touch on that at the end. I think that it's ironic that we spend thousands of hours in residency studying, but ultimately the goal is to get a job. And if you just spent 10 hours throughout your residency strategizing, networking, planning this kind of thing, you could change your whole career path. And I think that's something that it's easy in residency to get lost in the weeds of trying to memorize differentials and show up to work. But remember that there's the ultimate goal. So today we're going to be giving you some strategies about that. How to get a job. I think in terms of the anatomy of a good job candidate, this breaks down into 4 categories: residency competency, your personality, fellowship, and connections. In terms of residency competency, you can divide this into diagnostic skills and procedural skills. Under the diagnostic skills, obviously accuracy, speed, and detail of your reports. And in terms of touching a little bit on these, I think speed is something that is one of the first questions that people will ask you. I canvassed a bunch of jobs out here in California just out of curiosity, and they will ask you very quickly in the call, what's your speed like? Volume is a big thing. Detailed reports, I'll point out that this is dependent very much on the group you're in and the clinicians that you're serving. I think ultimately you're delivering a product to your clinician, right? So that is going to be dependent on who you're working with. We're going to touch on some of these other categories now. So in terms of your diagnostic skills, again, community practice volumes are very high. And I think that it's easy to go through residency not being able to handle volume. Obviously, when you're a junior, you need to focus on learning first and developing that foundation. But as you get into your senior years, start thinking about volume. The thing I want to point out here is that speed is permitted by knowledge. You can't just say, I'm going to be fast and I'm just going to go through things quickly. You need to have that basis. You need to know what dangerous things look like, and you need to know what the weird things are. If you know what all the bad things are, you're not going to mess up too much. Obviously, you're going to miss a few things along the way, but as you go through cases, you're also going to build your search pattern. So don't be too afraid about that in residency. The other thing I want to point out is working on plain films. I think as transitioning to staff, I spent a couple of months working as staff in the summer. Most residents nowadays don't get enough plain film exposure. Obviously, I think that there's a big emphasis on cross-sectional because there is so much to know. But Remember that plain films are still the backbone of radiology, and you need to be able to handle a lot of them and dictate them well. What I recommend is trying to fit in as much plain film experience as you can throughout residency, just filling in cracks here and there when you have a few minutes. If you can, try and read them out with staff. This will depend on the institution. Some places will just have, sometimes staff will just sign up your reports. You want to have as much readout time as possible because they're going to actually point out the findings so you know what they look like. Procedural skills. This is huge, and I think that your procedural skill is ultimately what makes you irreplaceable in radiology. Two things that are going to threaten you at some point could be AI and teleradiology. Coming down here for fellowship in California, opened my eyes to how big teleradiology is in the US. It's much more than in Canada. And in fact, we have these big Nighthawk groups where you have large conglomerates of radiologists who just work nights. So it's actually very rare for you to actually have to work nights in radiology here in the US because there are Nighthawk groups that cover that. So what that means is there's going to be a teleradiologist somewhere on the other side of the country covering your night work. But what's also happening is that there's more and more remote work that's getting delegated out. So University of Southern California has actually started hiring some people to read their daytime work in other states. Now, you can imagine that this can start to be dangerous for your job position. But what I realized is that they always need someone on the ground, on deck to cover procedures that you can't get away from. So having that skill set will make you invaluable, and I would not take that lightly. In terms of procedural skills, I'd recommend trying to get as broad an exposure as possible. Again, you're that man on the ground who's just covering things, right? So if you are missing a major core procedural skill that they need you to cover, now you can't be alone anymore, right? If you can't, put in a chest tube, then you can't be unsupervised on site, or you can't function alone. So that makes you less valuable. I've divided these up into three kind of categories. The first one is your bread and butter. I think everyone should be able to do ultrasound guided and CT guided biopsies and drainages, joint injections and facet blocks. This is fairly basic radiology procedure. Second category is more a little bit higher level. I think if you can get exposure to this, it would be nice. It'll depend on what practice you end up in. Central line placements are just a crucial central skill, I think. Perc nefs, G tubes, chole tubes, biliary drains. And then down here, we have more IR type things like fistulograms, angiograms, IVC filters, vascular IR. You're probably not going to need to do so much of this unless you're actually going to in more IR position. Next big category, personality. I think that this is going to be the biggest category once you get to the sort of interview stage. In the end, joining a radiology group is just joining like a work group, right? You have to get along with the people. The first thing is we look for people who are hardworking, so taking responsibility for the list. Again, I think that in residency, it's easy for people to just kind of pick up a few cases and like take their sweet time, but you have to start thinking about that when you're staff, like when you go from PGY5 or fellow to staff, that's going to be your list. So just keep that in mind. You want to be willing to do all types of cases and procedures. So as a resident, I would really recommend that you try and be open to taking any opportunity that comes your way, because you don't know what you're going to end up having to cover in your practice. And having that skill set, at least being able to market that, will be very useful. Offering to help with administrative tasks and rounds is a good way to show that you are wanting to get your hands dirty. Being easy to work with is a big thing. And I think having a positive attitude and fitting into the social culture of your group is going to make a big difference. I think that you'll obviously get a sense of what different groups are like and try and find one that fits well for you. And finally, being flexible with scheduling and call. In the end, again, this is just work. Like we need bodies to fill our call shifts and fill our different seats. So being flexible with that is really useful. And no one likes someone who doesn't want to take call. It's part of the job. It is what radiology is nowadays. In terms of fellowship, a few tips on choosing that. I'd recommend going into what you're interested in. I think it's so difficult now because you have to choose fellowships so early. where it's hard to predict what people are going to need down the line. In terms of going away for fellowship, I don't think it's necessary. It can be helpful depending on what kind of skill set you want to bring back. So if a group finds that, you are bringing a different skill set back, that could be helpful. I would look for a breadth of cases and procedures that matches what you are ultimately going to be doing in your practice. I'd recommend going for a more tertiary center because you want to see those weird cases in fellowship. That's my opinion. And staff to fellow ratio, having more staff means just more face time and more learning. Finally, you can talk to the groups that you're interested in and get a sense of what they do and what you might want to bring back. This is going to be very valuable because there's probably not a lot of groups that are going to be interesting to you depending on what location you want to settle down in. So having a sense of what they need will guide your decision. And connections, having a longitudinal relationship with groups that you're interested in is going to be really important. I think that the devil you know is better than the devil you don't. And having that, opening those conversations early is going to be valuable. So reach out early, stay in touch, do site visits if you can, and do electives whenever possible. I think will be valuable for positioning yourself for a job. How to choose a group, a couple of notes here. First of all, first branch point is going to be academic versus community practice. You probably have a sense of that already. Location is going to be really big for you. And I think that thinking about where you want to settle down is going to dictate a lot more of what happens after. The culture of the group, again, this varies by the group and you have to meet the people to see what they're like. Speed, sensitivity, and detail of reports are also kind of like the culture of the group. Different groups are set slightly differently in how they function, right? So if you are a very detailed, meticulous reporter, you may not fit in as well in a really high volume, like crushing type group, versus if you're a very concise, efficient dictator, you might feel the odd one out if you're joining a very, very detailed group where they expect like long reports type of thing. And lastly, workload, can you handle it? And is that something that would fit into your lifestyle? Other questions you can asking about call, what's the frequency like? What are the volumes like on call? How much do people sleep? That's going to be big in terms of your quality of life. Breadth and complexity of cases. So is this something that you want to do? And is that interesting to you? If you want to do general practice, I would recommend trying to keep your skills as broad as possible early on. I think that developing those skills early will make you more marketable for, potentially other jobs if you ever have to change careers, and it will just help you sharpen your skills. Are there opportunities to work from home? That's another thing you can ask. And how much do people work? This is also somewhat of a cultural thing. There are some groups that maybe for them, they don't want you working more than 4 days a week. You may love that if you want that lifestyle, or you may, want to work more if you're trying to make a lot of money kind of thing. So ask about that. So that's it. Thanks for listening. There's my email. I am recruiting for Royal Columbian Hospital. We're 30 minutes out from Vancouver. It's a tertiary center, but it's a tertiary center level care.
Everyone, thanks for the introduction, Kathleen. As Kathleen mentioned, I'm a staff radiologist at Dalhousie. I did my fellowship 2 years ago at the University of Toronto, the Joint Department of Medical Imaging, and I primarily practice musculoskeletal imaging with a bit of general radiology as well. And I'm excited to be here today and give you guys this talk. So I'll try to stay within my allotted 25 minutes so that you guys have time for questions after. So I'm going to be talking today about approach to metabolic bone diseases. I do not have any conflict of interest to disclose. Metabolic bone diseases is always a topic that I think everybody sort of freaks out about a little bit. And that's because there's a lot of overlapping imaging features. It's not something we necessarily see very frequently in clinical practice. And as you'll see in my talk, a lot of the findings are initially detected on radiographs, which as the new generation of radiologists, we're not quite as strong as our predecessors in interpretation of radiography. And so I'm hoping today I'll be able to show you lots of cases of radiographs, and you can keep an eye out for these findings in your own practice. So I won't go over those objectives. They're there for you to review. let's start with a case. So 67-year-old male, history of sacroiliitis on pelvic and hip radiographs. Please confirm the findings with CT. So we have images here. Can you guys see my pointer? You can?
Oh, we
I don't
can't
think
right
we can.
now. No, I wonder.
That's okay. I think it'll be okay. But let me know if I might actually be able to use the one, this guy. It's because I'm like screen projecting, so I have my notes.
Oh, I got you.
Yeah, I think it should be okay though. So we're going to talk about, I just want to leave these images here, give you guys a second to look at them. Kind of formulate what you think is going on, where the main sites of pathology are. And then we're going to go to the next slide again. Kind of think in your mind this is the same patient, what we're putting in our differential. And then a third final slide with some ancillary findings that may be helpful to you. So the most likely diagnosis is A, infection, hyperparathyroidism, B, C, renal osteodystrophy, or D, both C and D. So I want you to try to commit to one of those now, and we're going to go through the talk, and I'm going to ask you this question at the end, and I'm hoping that everyone can get the answer right. All right, so an approach to metabolic bone diseases, you're going to hear this multiple times throughout the talk. The biggest things with metabolic bone diseases are the past medical history of the patient and the laboratory investigations. We really rely heavily on those to narrow our differential diagnosis because there's a lot of overlapping imaging features with other MSK pathologies. When we talk about past medical history, we want to know about pre-existing medical conditions like hyperparathyroidism, chronic renal disease, understanding that that information isn't always given to you. Medications such as corticosteroids, bisphosphonates, prior history of fragility or insufficiency fractures. Lab tests, honestly, things like creatinine are very helpful to determine if there's renal dysfunction. ALK, phos, PTH, if that's available, can be useful as well. Sometimes that is done before the imaging, so helpful to review that. And then the third thing we're going to do is then look at our imaging, and we're going to integrate what we see on imaging with those other findings, the history and the laboratory investigations. And we do this a lot every day in radiology, but I just want to emphasize that for metabolic bone diseases, this is absolutely critical. So we're going to talk about osteoporosis first. That is the most common metabolic bone disease. Osteoporosis is due to decreased bone mass from both reduced bone formation and excessive bone resorption. Risk factors for osteoporosis include female sex, age, particularly postmenopausal patients, low BMI, past fragility fracture, family history, smoking, alcohol. Those are all kind of like the common risk factors for osteoporosis without another cause. Now, there's also a secondary form of osteoporosis, which is related to medication use and pre-existing conditions. So I've listed some medications here. Corticosteroids is the one we remember the most, but also associated with aromatase inhibitors for patients who have breast cancer, androgen deprivation therapy, and then pre-existing conditions such as rheumatoid arthritis, malabsorption, hypogonadism. So those are all there for you guys to review after. The imaging findings in osteopenia and osteoporosis, I'm going to kind of group those together, is essentially diffuse osseous demineralization. So we're going to see a washed out appearance to the bones. The other described finding is the second metacarpal index. So the width of the medial and lateral cortex combined of the metacarpal shaft is less than that of the medullary cavity width. We also have findings in the long bones, including reinforcement lines and punctate periarticular lucencies. In the spine, we can see trabecular coarsening or unmasking of the trabecula and increased end plate density. So let's look at a few examples here. On the far left, we have an example of the second metacarpal index and how that is narrowed in this patient. So when we add the medial and the lateral cortex together, it equals less the width of the medullary cavity. When we look at trabecular accentuation, if you see in the spine here, I can see all the individual trabecular markings really, really well. And the end plates look really dense, and there's almost like you could draw a pencil across them, nice and sclerotic. That's because when we lose that bone mass, the leftover trabecula in the bone become more prominent and stand out more to us. The reinforcement lines are the third image. And then finally, the periarticular lucencies. This can be a tricky one. You can see this too related to disuse osteopenia. And I find I get consulted on this occasionally because people wonder, is this a multiple myeloma that I'm gonna end up missing or calling osteopenia? And the key thing is to look for osteopenia in other sites of the body, look at the patient age, and usually you won't see discrete punched out lesions as we do see in multiple myeloma. It's just going to be hazy kind of punctate lucencies. Okay, so then we have to talk about fragility fractures when we talk about osteoporosis. So these are a consequence of osteoporosis. There's an estimated 37 million fragility fractures in the world annually in people over age 55. So this is a huge issue, you know, with morbidity and mortality. And the common locations for these are the lumbosacral spine. Those automatically characterize a patient as high risk, no matter what their BMD, bone mineral density says. Distal radius, and proximal femur and proximal humerus. The key thing with these is they occur after minimal trauma. So we, you know, fall from standing height or less. Sometimes it can even be the patient coughed or rolled over in bed, like very, very minor trauma. So when we look at there's some examples of the fragility fractures, which you guys would see every day: compression fracture, distal radial fracture, and proximal humeral fracture. And you can tell in all these cases, the bone mineral density is down. The gold standard for diagnosing osteoporosis is DEXA, dual energy absorptiometry. That's kind of beyond the scope of this talk, but essentially what you need to know is that we assign the patient a T-score by looking at several different sites, including the lumbar spine, proximal femur, and sometimes the wrist. And we compare that score. If it's a T-score, we compare it to basically the average bone mass of a normal, healthy patient, or we can sometimes use a Z-score, which is an age match. This is an example from our own institution of a patient's BMD report. The arrow is showing you the T-score, and we know based on our previous slide, the T-score is less than -2.5. Therefore, this patient is going to be delineated as high risk. And in our center, we issue a report that includes some recommendations for additional investigations to do, and of course, treatment recommendations with vitamin D and other first-line pharmacotherapy. Atypical femoral fractures occur in patients who have on long-term bisphosphonate therapy. So those patients with osteoporosis, we put them on bisphosphonates, and if they're on that for a long time, like 3, even 5 years, they can get these atypical femoral fractures. They're subtrochanteric. About 80% of them occur within 5 centimeters of that lesser trochanter, and they're very frequently bilateral, so 30 to 50% of cases. Again, minimal to no trauma is what results in these fractures. So let's look at some pictures here. So we see this focal area of cortical thickening in the lateral femoral cortex. This is an early sign of these atypical femoral fractures. You get cortical buttressing and thickening. It's very subtle. What is the next step for this patient? Well, we just talked about how almost 50% of them can be bilateral. We need to image the contralateral femur along its entire length to make sure there's not another fracture. And this is a nice example of a patient who fell while walking with their dog with bilateral complete atypical femoral fractures. And you can see the pattern of this fracture is different than people who come in with a higher energy mechanism of trauma. There is a more transverse orientation to the fracture. It's not comminuted, and we have a very prominent medial spike, right? So sometimes when we don't know the history well, we're like, okay, how are we going to know that was an atypical femoral fracture? Where you're going to look at that lateral cortex and you're going to see that nice sharp transverse line and then that medial spike. All right, moving on to rickets and osteomalacia. These are diseases that are caused by a number of different issues with the vitamin D pathway and calcium and phosphate metabolism. So there's some of the causes include inadequate vitamin D intake. So this could be from poor nutrition, malabsorption syndromes, reduced sunlight, poor metabolism of vitamin D, which can be related to liver disease or kidney disease, vitamin D resistance, and other rare genetic things like X-linked phosphatemic rickets. When we compare rickets and osteomalacia, the way we want to think about this is really kids and adults, and where the abnormal unmineralized osteoid is being deposited. So in rickets, there's impaired development and mineralization of the growth plate specifically. We're going to expect to see widened, irregular physes, metaphyseal fraying and cupping. That's the key thing with rickets, bowing and fracture. In the chest, we'll see a rachictic rosary. So you have very prominent kind of expansion of the ribs in these areas. And you can see skull findings like a flat occiput or squaring of the skull. With osteomalacia, we see that unmineralized osteoid being deposited in the cortex and the trabecular bone of adult patients. And the classic finding for osteomalacia is looser zones. So of course, those patients are going to have reduced demineralization. They're going to have the same findings that we see in osteoporosis, but they can develop these looser zones, which are pseudo fractures, essentially transverse fractures that are perpendicular to the cortex that occur in these really classic locations. The pubic rami, the lateral scapula, which isn't really a place we typically see fractures, the proximal ulna, and the ribs. Because the bones are so soft with osteomalacia, we can also see acetabular protrusio, and we can see concavity of the vertebral body end plates. This is a really nice example of a local case of hypophosphatemic rickets. You can see that the growth plate is very irregular and sort of smudged looking. We have areas that are devoid of osteoid along that growth plate, and it's cupped. So it has the kind of margins, cupped margins that we expect with rickets. And typically you'll see the findings in rickets in the long bones and areas of rapid growth. So we'll also see findings of rickets in the wrist. And this is another local case of rickets and metaphyseal cupping and fraying in the wrists. And we've got the bony bowing that we see as well with rickets on the image on the right. And this is an example of osteomalacia. So this patient has a looser zone in the femoral neck, which is sclerotically marginated. And then on subsequent imaging, they go on to develop a complete fracture. So again, it's that orientation, that transverse orientation perpendicular to the cortex that tips us off to this possibly being a looser zone or a fracture related to osteomalacia. An example of osteoprotrusio in a patient with osteomalacia. So you can see both the head and the inner wall, the medial wall, the acetabulum, are protruding far beyond the ilioischial line where we would expect them to be. So that's an example. All right, so moving on to hyperparathyroidism. I think this is one of my favorites for the metabolic bone diseases because the imaging findings, I find them cool. Some of them are very specific and helpful if we can see them. So elevated parathyroid hormone, essentially, it leads to increased bone resorption. And so PTH is known to activate the osteoclast and cause increased bone resorption and breakdown. When we think about hyperparathyroidism, we have both the primary and secondary forms. Primary, most commonly, 90% of the time, is caused by a parathyroid adenoma, but there are other causes as well. Secondary is caused by chronic renal failure. Now, that's going to be really important when we go forward looking at more of the imaging findings. With primary hyperparathyroidism, there's a lack of inhibition of PTH secretion. So the parathyroid adenoma is just continuing to excrete PTH without any feedback loop, and that's stimulating osteoclast bone breakdown and bone breakdown. Secondary hyperparathyroidism from chronic renal failure results from increased phosphate levels, which then leads to decreased calcium. And then the feedback loop is to go back and cause hypertrophy of those parathyroid cells to make more PTH. And so that's how we end up getting some of these bone findings from chronic renal disease. The imaging findings of hyperparathyroidism include the subperiosteal resorption in the hands along the radial aspect of the second and third middle phalanges. I remember as a resident reading this all the time, but never seeing a case and thinking if I eventually did see a case, I'm probably going to miss it because I don't have any examples. So I'm going to show you some nice ones. And then acroosteolysis. Important to know that hyperparathyroidism, though, can cause bony resorption at several other sites. So not just subperiosteal. It can cause subchondral resorption. So if we think of them in categories, subchondral resorption, okay, distal clavicle osteolysis, that's going to be possibly related to hyperparathyroidism. The sacroiliac joints, the sternoclavicular joints, vertebral body end plates, and some of the large joints even. There's also can be subtendinous and subligamentous and subfascial resorption too. So just remember that all these sites where like tendons and ligaments come and attach, we can get bone resorption in hyperparathyroidism. You can also see periarticular and soft tissue calcifications as well. So this is a really nice example of subperiosteal resorption, the second and third middle phalanges along the radial aspect. And you can see it's very hazy and irregular. We're losing that normal crisp edge of the bone that we see on the ulnar aspect of that. This is another example showing acrosteolysis and soft tissue calcifications in a patient with hyperparathyroidism. And it would be, you could argue in this case, well, what about one of the connective tissue disorders like scleroderma for this? Because they have the acrosteolysis, which we see with scleroderma, and they have some soft tissue calcification, and that would be reasonable to include as well. Other things in the differential for acrosteolysis are listed here, and that's just a short list. There's a big long list and a bunch of mnemonics to remember them, but remember hyperparathyroidism is one of those causes. This is a really nice local case, and they actually had bilateral resorption at the plantar fascia origin. So you see, again, the bone is really ratty where the plantar fascia comes and inserts. A nice example of subchondral resorption of the distal clavicles. Again, like acrosteolysis, there is a differential for this. We want to think of things like rheumatoid arthritis as well as mechanical or stress-related resorption from the distal clavicle, so distal clavicle osteolysis. Those would be the main things. Sometimes soft tissue, connective tissue disorders can cause this as well. And this is kind of a acute case of subtendinous resorption at the lesser tuberosity. So there's a little bit of bone missing there where the iliopsoas tendon is coming inserting. All right, so moving on to a couple other findings. In the spine, we have Rugger jersey, which is alternating sclerotic and lucent bands throughout the vertebral bodies. In the skull, we can see the salt and pepper appearance with multiple punctate lucencies. And then we have Brown's tumors. So Brown's tumors are osteoclastomas. They're essentially lytic lesions that result from PTH activation of osteoclasts. They can be solitary or multifocal. Common sites include the facial bones, which is usually an odd place otherwise to get a lytic bone lesion. So that should tip you off that location. The ribs, the pelvis, and the femur. And these are at increased risk for path fracture. So is this a nice example of a Rugger jersey spine? We have those dense end plates and the lucent vertebral bodies that look like a rugby jersey. I'm not a rugby fan, but I found a nice rugby jersey. And I do think they look similar. So the lytic lesions that are also denoted with the arrows, when we see this look to the Rugger jersey spine, and then we see those lytic lesions, we're thinking Brown's tumors, right? Whereas in a patient who didn't have the other bone findings, we would be putting metastases up on top of that list in the differential. This is another cool case of extensive Brown tumors. Wild, like totally remodeling the entire pelvis. They're in the proximal femur, all of the ribs, most of the ribs are involved. And a cute sort of hint to this one is that you see in the right iliac fossa, there's this calcified focus. So this patient had a remote renal transplant that was calcified. And so all of a sudden we're like, okay, all the bone findings combined with the probable history of renal dysfunction, this is probably Brown's tumor. So Rugger jersey and Brown's tumors were originally described in primary hyperparathyroidism, but now we observe them more frequently in secondary hyperparathyroidism from renal disease. Okay, so there we go. We've got our salt and pepper skull. So we have multiple punctate lucencies in that skull, and you can see the CT as well, all these tiny little areas of lucency. So renal osteodystrophy, this is where people get a bit confused. So it is a constellation of findings that we see in patients with chronic renal insufficiency. There are overlapping features with osteomalacia and secondary hyperparathyroidism because of what I described in the previous slides. Secondary hyperparathyroidism is associated with chronic renal disease, so we're going to see overlap of those. Again, findings could include osteopenia, so reduced mineralization, or osteosclerosis. So I do see patients frequently, incidentally detected increased sclerosis of the lumbar or thoracic spine on studies done for other reasons, and it's usually related to renal disease. And then the features of secondary hyperparathyroidism, which we discussed before, and you can also see looser zones. So they're all kind of interconnected, which is one of the things that makes this challenging. This is an example of a patient with proven renal osteodystrophy with diffuse osteosclerosis. So when we look at this thoracic spine, it's just too dense the whole way through. And then we've got the rugger jersey appearance more in the lumbar spine. So that's a nice example. And in the same patient, they had very sort of early stages of subchondral resorption at the SI joints. So that's a nice example of subchondral resorption related to renal osteodystrophy. And I got to put a bone scan in here. I'm not a nukes person, but you can see these metabolic bone diseases obviously on nuclear medicine exams. And this patient had diffuse uptake in the skull, in the spine, in the SI joints, in the pubic symphysis. And they also had a known history of renal osteodystrophy. So that was all related to that process. I'll briefly touch on thyroid disorders. Honestly, I have never come across one of these in my practice. Hyper and hypoparathyroidism in adults usually just presents with osteoporosis. Like that's the main imaging finding you'll see in those patients. You'll read in textbooks about thyroid acropathy. It's this very rare disease which occurs in thyroid toxicosis, and you have classic imaging findings of really prominent periosteal bone formation along the metacarpals and phalanges, digital clubbing, and soft tissue swelling. So I do not have an example to show you guys this because I haven't come across one yet. But if you guys see one, I'd love to hear about it. And then in children with hypothyroidism, they often have delayed skeletal maturity and delayed bone age, short stature, and they can have these really stippled epiphyses as well. And that's kind of a unique feature to hypothyroidism in the pediatric population. Of course, scurvy is another one we have to think about when we think about metabolic bone diseases. Vitamin C deficiency leads to impaired collagen synthesis and increased bleeding. So when we think of increased bleeding, these patients will develop subperiosteal hemorrhage and periosteal reaction. They'll develop hemarthrosis. And when we look generally at the bones in a patient with scurvy, they'll have osteopenia and thin cortices. They're called pencil point, very, very thinned out. Then there are a number of characteristic findings that you'll read about in the literature, and we're going to go through some of those. So subperiosteal hemorrhage, you have your example on the left side, big expansile areas of periosteal bone formation, tracking the whole way down the femur and the tibia. That's an example of subperiosteal hemorrhage. If we didn't know about the vitamin D deficiency, we could put things like neuroblastoma, leukemia also in that differential. But then we look also at the growth plates. So you can see here that there's this really dense sclerotic line at the metaphyseal side of the growth plate. That's called the Frankel line. That's the provisional zone of calcification. And that's where we see this increased dense mineralization. We also have the Wimberger ring, which is this cortical thin area around the outer cortex of the epiphyses. So just the density that's around there is the Wimberger sign. And then another example here showing the Trummerfeld zone. So underneath the Frankel line, you get a lucent line. That's the Trummerfeld zone. And then along the medial aspect of the metaphysis, that little spur that you get that can sometimes fracture is called the Pelkin spur. So last thing we're going to discuss is Paget's disease. This technically falls into metabolic bone disease. It's hard to know sometimes where to put Paget's, and we don't really see it that much anymore. So it's a chronic metabolic bone disorder of uncertain etiology, partly linked to genetics, probably environmental factors. It has been connected to paramyxovirus. And actually, some more recent studies have suggested that the Paget's disease incidence has decreased, in part related to improved vitamin D intake in the elderly population. More foods are being supplemented with it. So I think that probably has a role as well. 3 phases of Paget's disease: the osteolytic phase, which is increased osteoclast activity resulting in increased bone resorption and lysis. So you get a blade of grass sign. The mixed phase has both osteolysis and osteosclerosis, and you can see the picture frame vertebra. And the sclerotic phase is the one we think of when we think Paget's: expanded bones, thick cortex, coarsened trabecula. 1% to 2% of cases of Paget's disease can undergo sarcomatous transformation, and osteosarcoma is the most common cancer that we'll see. So a few examples here, local examples: blade of grass sign, nice sharp margin of that area or zone of osteolysis in the tibia. We have the picture frame vertebra, so you can see the vertebra is just dense and enlarged compared to the other vertebra. And there's kind of a lucent rim at the outer margin. And then kind of an interesting place, usually we see it in the pelvis, but in the proximal humerus. If you get these cases on the exam, you're going to start describing the findings. And even though it might be a weird place, you're going to say, oh yeah, well, cortical thickening, bowing, trabecular thickening, and then you're going to say Paget's disease, because even if it's a weird place, those are all the features that we see in Paget's disease. Nice example of a cotton wool skull in a patient with Paget's disease, and the MR can look totally wonky, expansion of the marrow, heterogeneous. And this is just one of the cases I have of Paget's disease from our institution that underwent sarcoma degeneration. So at the 2-year follow-up mark, the patient had a hip arthroplasty and then developed this lytic lesion in the inferior pubic ramus, which was proven to be an osteosarcoma. So I'll leave this here for you guys to review, but essentially just reiterating the fact that in all of these cases, we really need to know the history. We need to know if there's any relevant labs. And then the most helpful thing is to look and see if there's any of those pathognomonic features that I described during today's lecture that would help point you in the direction of one metabolic disease or another. And you can look for other cues in the imaging. Sometimes I'll go back, like if a case is shared with me, I'll go back and see like what other joints have they looked at? What did the spine look like? Were the kidneys atrophic? You know, do they have known renal disease? All those sort of things can be helpful in arriving at the diagnosis. So if we look at our case, we have subperiosteal resorption at the SI joints and at the pubic symphysis. We have a really nice Rugger Jersey spine. We have clearly polycystic kidneys and polycystic liver. So we know there's probably a degree of renal impairment here. And the answer is both C and D. This patient has signs of secondary hyperparathyroidism because of their underlying renal dysfunction. So they kind of, it's both that we're seeing on this person's imaging. All right, that's it, guys.
Try to see if I can change these slides. Okay, so no conflicts of interest. All right, so I'll be addressing today some challenges encountered during transition to practice, which is a rather challenging, arduous topic to discuss in a formal setting like today. Therefore, I highly encourage everyone to ask questions and make this session more interactive. As a caveat, obviously, the contents of this presentation are highly personal in the sense that I'll be talking about my experience with fellowship training in the US and practice in Quebec, which have some particularities that may not be applicable to everyone. I therefore highly recommend you consider this from your own perspective and seek additional insight if needed. And learning objective is to identify several challenges encountered during transition to academic practice. And I will be framing the challenges as a list of pearls. Some of these I was able to take into account and implement myself from the get-go. Others are things that I wish I knew beforehand and dealt with better. So hopefully you won't be making the same mistakes as I did. Sorry, just move ahead. All right, so first, pearl, moonlight during fellowship. If you have the opportunity, one of the biggest challenges that we faced at the beginning of our practice is suddenly becoming that last person to sign off on that report. No more attending to back us, and this uncertainty can be quite daunting. I find that moonlighting can help ease with this transition. It allows to build confidence and some experience making these calls, and you learn how to manage some tricky situations, like when you're unsure of the diagnosis or of the recommendations. And you know, moonlighting opportunities are usually general radiology, so this sort of implies easier and more straightforward cases where you can you have the latitude to develop these skills. And these skills are highly transferable to situations where you are dealing with more complex or specialty cases, which you will be faced with in your practice. Another benefit of moonlighting is developing efficiency and speed in your reporting. My experience with training is that you do have some opportunities to work with those, especially towards the end of residency and fellowship, but these are quite limited. As you know, as a trainee, you focus more on acquiring knowledge and skills and less on reporting faster. And boy, do you need to be efficient in radiology in 2025. So That's something you can work on during fellowship and during moonlighting. And obviously, the financial advantages of moonlighting can be another factor to consider if revenue is a priority to you. All right, pearl number 2, and I cannot stress this enough, guys. Take time off between end of training and beginning of practice. You know, during medical training, we go hard for what, 10, 15 years. Most of us basically have 2 instances where we get scheduled significant time off, you know, a couple of months before medical school, a couple of months before residency, and that's it. You know, a residency ends on June 30th, fellowship starts on July 1st, and you're still shell-shocked from your Royal College exam experience. And the next thing you know, you're trying to adjust to a different institution, to a different city, or even a different country. Takes at least a month to start feeling more comfortable in your fellowship, and then it goes by pretty quickly. So I finished fellowship in June 2023. I started my practice in October, so I had those 4 months off that allowed me to, you know, travel to places that I've always wanted to visit and finally get married after 10 years of being engaged. So 10 out of 10 would recommend. Highly useful time. All right, start slowly. Beginning of practice is probably not the best moment to start, you know, developing, implementing new techniques and interventions that you learn in fellowship in your new practice setting. You may need some time to get comfortable with reporting and performing interventions independently, and get used to other tasks like, you know, teaching, taking call independently. So it's also probably not the best time to start working in different workplaces, meaning if you have the opportunity to do some locum work or outpatient clinic, give it at least a couple of months to get comfortable at the hospital before you dive in a different setting. It will be much easier to get used to another new environment once you've gone through the process already at the hospital. And since you already will have learned what your preferences are in terms of, for example, protocols and procedure setups. All right. Experiment with general radiology in your subspecialty practice and or diversify practice location. Now, this is highly personal, and it involves knowing what you want from your practice. You may know from early on that you want to do just one type of subspecialty, which, such as in my case, I knew I wanted to be an MSK radiologist in second year of med school. So, you know, you have this idea as a trainee that it's the only thing you'll ever do, and chest radiology is the most boring thing on the planet. But you know, I've had the opportunity to do some general radiology work at the beginning and in outpatient clinics. And honestly, it came as a surprise, and I found it to be super rewarding as well. It just allows me to diversify my practice. Hospital work is very challenging, a lot of very complex cases and interventions, and that take time and effort and can be very taxing. And probably I don't think I'd be able to exclusively work in a hospital setting because of how, you know, intense this work can be. And doing a bit of general radiology work is a very welcome change of pace. And again, it's not something I would be doing exclusively either, because I would miss my time at the hospital and the challenges that I get with these more, you know, advanced cases. So I guess it's about finding that balance. You know, the beauty of our specialty is that our services are in such a high demand that we have the opportunity to shape our practice. And I encourage you to reflect on this while you are in training and see what you think you may enjoy. All right, pearl number 5, learn about the intricacies of billing. I don't know how much of this is applicable to the rest of Canada and to different practice settings, but in Quebec, billing is a whole science. You need to have a pretty good understanding of how things work early on, and this is not something that is addressed during training, at least not at University of Montreal, and I believe not elsewhere otherwise. So, you know, if this applies to you, try to have an introduction into how to manage billing. In Quebec, there are some seminars offered by billing companies which give you some working knowledge that you can, you know, sort of build on once you start. And I encourage you to address billing with your colleagues at the beginning and have an understanding of local practices that may vary as well. All right, so seek expertise to plan around your life and financial goals. If you do not already have a financial counselor, I highly recommend you look into getting one, even if you're still in training. Beginning of practice obviously implies a change in revenue, and that has an incidence on a multitude of aspects of your personal and professional life, ranging from invalidity and life insurance to purchasing at home, how you do your taxes. So, a lot of implications there. And if you're not particularly well versed or keen on managing money, and very few of us in medicine have this financial literacy, you may be missing out on all sorts of opportunities if you do not have a team of professionals to help you. So we are very resourceful individuals in medicine, and will be able to find an answer or a solution to anything, but at the cost of significant time and effort. And there will be a moment when you realize that you just cannot do everything by yourself, and delegating these tasks will allow you to focus on things that really matter to you. All right. Keep learning, ask for help, and challenge yourself. As cheesy as it sounds, it's inevitable that you won't know everything coming out of training, and you'll have to perfect some skills. Especially if you end up working in a setting with slightly different practices from what you were used to in fellowship or residency. A lot of variability between the practices. So you may and likely will end up having to interpret imaging and perform procedures you've never done before. And I think one of the roles of training is not to necessarily make you an expert, but a safe learner, meaning you have the ability to learn a new skill while knowing your limitations, and when to seek help and guidance. You may have never done a perineural injection of the posterior interosseous nerve before, but you've done enough perineural injections in your life, and you've done enough ultrasound that you'll be able to find that nerve and adequately target it and adequately inject it. So invariably, you will have to ask for help, and more experienced colleagues are usually there to help.
This session is about an approach to sacroiliitis and how to evaluate for sacroiliitis when you're presented with a case of such. So nothing to disclose from my point of view. So the objectives over the next 25-30 minutes is to discuss the imaging criteria necessary for the diagnosis of sacroiliitis, and also to describe the imaging features that differentiate inflammatory sacroiliitis from its mimickers. So that is the fundamental issue that we face when we are dealing with sacroiliitis. First is to diagnose sacroiliitis, and second, is this really sacroiliitis or is it something else? So we'll get on to that. So sacroiliac joint imaging, it's a very difficult joint to image to start. Why? Because of its complex anatomy. It's not in a single plane. It's got undulating articular surfaces. So the X-ray beam can't see it in one plane at all times. So you have to be careful about that. And also, the superior 1/3 of the sacroiliac joint is fibrous, and the rest, the inferior 2/3, is synovial as well. It's a synovial portion that we are interested in when we are talking about inflammatory sacroiliitis. The fibrous portion we're not really interested in when it comes to inflammatory sacroiliitis. So when we look at a CT, for example, so this is sort of an axial CT slice from the superior aspect of the sacroiliac joint. So you can see superiorly, the synovial portion is anterior, so noted by these yellow arrows. And the fibrous portion is along the posterior aspect. And you can see the fibrous portion is much wider compared to the synovial portion. And when we move inferiorly, again, in the transverse or axial plane, you can see that it's predominated by the synovial portion. So it's this inferior portions, the inferior 2/3, that we are interested in when we are evaluating for an inflammatory sacroiliitis. Now, if we look at the X-rays on this side, so you can see we are looking for this tram track appearance, so the parallel articular lines of the sacroiliac joint. And the important thing to note is this white line, which is the subchondral bone plate or the articular cortex of the sacrum and the corresponding ilium. You guys can see my arrow, right?
Can see the arrows, but not. Oh, your cursor as well. Yeah, we can see. Thank you.
Oh, you can see my cursor. Yeah, that's what I was asking for. Let me put a highlighter on. That will probably be easier. Okay, there you go. That's probably better. So yeah, so this white line is a subchondral bone plate or the articular cortex. That is what you want to see. Every sacroiliac joint that you image, you want to follow that white line of the subchondral bone plate all the way along the sacroiliac joint. And I told you earlier that it's a difficult joint image and it's got undulating articular surfaces. So you will see multiple planes of the sacroiliac joint in one projection. So you can see the anterior aspect of the sacroiliac joint here and the posterior aspect of the sacroiliac joint over here. So you have to evaluate both positions of both margins of the sacroiliac joint on the plane radiograph. But the important thing to remember is you have to see that white line of the subchondral bone plate, and that is very critical in evaluating for an inflammatory sacroiliitis. Now, X-rays, conventional radiographs are still the first line in imaging for diagnosis of an inflammatory sacroiliitis. So radiographs are useful for diagnosis of sacroiliitis, to assess for progression of the disease as well. But the problem with sacroiliitis is its sensitivity for early disease. So when you start seeing findings in plain radiographs of sacroiliac joints, the disease has already progressed further. It's 5 to 7 years since clinical onset of symptoms do we only see changes that happen within the sacroiliac joint. So that's a long period in the patient's disease pathway to be not treated. So that is why plain radiographs are good for diagnosis, but it's not a great tool for early diagnosis of sacroiliac joints. So that's when we move on to non-radiographic sacroiliitis and see how we image that as well. But for now, we'll look at how we diagnose inflammatory sacroiliitis on plain radiography. Now, can we use CT? You might ask. Yes, CT is better at looking at erosive changes. You can assess questionable abnormalities in here. So here are axial and coronal images of sacroiliac joints, CT, and you can see there's articular surface irregularity. You can see the irregular articular surface, and these little erosions on both sides of the sacroiliac joints can be seen as well. And then you're seeing the subchondral sclerosis on the iliac side, predominantly on the iliac side of the articulations as well. So yes, these changes can be seen in CT, and you can use CT to assess for questionable abnormalities. But do we use CT to make a diagnosis of inflammatory sacroiliitis? No, we never use CT to make such a diagnosis. We use CT because most of these patients may have inflammatory bowel disease related sacroiliitis. So you may, if you look in their patient's chart, they may have previous multiple CT scans of the abdomen and pelvis. So you can have a better look at the sacroiliac joints from there. And the other reason why we do not use CT is you can only see these structural changes like erosions and subchondral sclerosis. You're not going to see active inflammation on CT. So that's a huge drawback of CT as well. So CT is not routinely used for imaging of sacroiliac joints. It'll help us if the patient has had prior CT to make a confident diagnosis of inflammatory sacroiliitis. Now, when you're looking at a sacroiliac joint, so what, from a radiologist perspective, what does a clinician or the rheumatologist need is to tell them whether they have got sacroiliitis, and is the sacroiliitis unilateral or bilateral? Is it symmetric or asymmetric? Is it involving both sacroiliac joints in a similar manner or one worse than the other? And then a grading system needs to be used as well. So the American College of Rheumatology has this New York criteria for grading of sacroiliac joints. So let's discuss that. So the New York criteria it's been on for a long time. It was initially devised in 1966. So the New York criteria goes from grade 0 to grade 4. So let's get rid of grade 0 and grade 4 because those are the easy ones. So grade 0 is a normal sacroiliac joint, and grade 4 is where the sacroiliac joint is completely ankylosed. So those are easy to get out of the way. It's the in-between ones, the grade 1, grade 2, and grade 3 that we need to be careful about. So what is grade 1? So grade 1 is what we call suspicious changes. That it doesn't look completely normal, but you're not seeing what the abnormality is clearly. So it does not look completely normal. So that's where you would lump all the grade 1 into. Now, grade 2 and grade 3 are sort of increasing severity. So in grade 2, there's minimal abnormality, and grade 3, there is unequivocal abnormality. So let's first see what an unequivocal abnormality is. So there is definite sclerosis and or erosions, and there is joint space alteration as well. So there's either joint space narrowing or joint space widening. And grade 2 is minimal abnormality. So you can see some foci of sclerosis and maybe some erosions as well, but the joint space is still maintained. So that's the main difference between the two. So you're definitely seeing sclerosis and or erosions, and there is joint space alteration in grade 3, whereas in grade 2, you are seeing some sclerosis or erosions, but the joint space is still preserved. Whereas grade 1, you're not sure at all. There is some abnormality. This does not look normal, but I don't think that I see an erosion or sclerosis or ankylosis. That's where you would put grade 1 into. So as I said, it's easy to identify a normal sacroiliac joint. So all you need to do is to follow that subchondral bone plate or the articular cortex all the way, make sure the parallelism of the joint space is preserved as well. And grade 4 at the other extreme is often very easy to identify as well. So you're not going to see the sacroiliac joint as well, since the sacroiliac joints are completely fused bilaterally. So that is grade 4 sacroiliitis. Now the in between, so this is grade 3. This is one that you would classify as grade 3 bilaterally. So what we're seeing is, see the subchondral sclerosis on both sides of the joint, and it'll almost always be more on the iliac side of the joint. And if you look at the white line, you can't see that at all, the articular cortex, but there is also change in alteration in the joint space as well. The joint space is not a parallel tram track anymore. It's very undulating, it's very irregular. So those are definite erosions. So here now we're seeing definite sclerosis and definite erosions, but also the joint space alteration is there as well. So that is why you would call this a grade 3. So when you're grading sacroiliac joints, you can grade both separately. So you can say this one, if it's similar looking, you can say bilateral grade 3. But if it's asymmetric looking, you can grade one each side separately as well. That's absolutely fine. So here is grade 2, grade 3, and grade 4. Grade 4, as I said, easy to identify. You're not seeing a sacroiliac joint at all. And grade 3, you can see if you come down here, you can see very undulating margin, very irregular appearing margin of the sacroiliac joint. So that those are definite erosions, and then subchondral sclerosis as well. So when you get subchondral sclerosis, it blends with that articular cortex, and you're not going to see that thin line of the articular cortex. And grade 2, you are seeing some abnormality. So you can see here, there is some sclerosis, not much sclerosis going on in the anterior aspect. And is there an erosion? I'm not confident to say that there is an erosion, but the joint space doesn't look as irregular as this one, the grade 3 that we see. And often you can always jump between the two. So you can also say grade 2 to grade 3 as well. That's absolutely acceptable as well. If you are not sure that you're actually seeing erosions, but you're seeing a lot of sclerosis, you can always say grade 2 to grade 3. That is acceptable as well. So here is a 20-year-old patient with inflammatory back pain, and you can see this is bilateral grade 3 on this side, I would say. So you can see there's definite sclerosis. There are erosive changes. It's not a straight line, the articular surface. It's very irregular and undulating. On the right side, again, you're seeing sclerosis along the iliac side of the joint. The joint space, you can see some irregularities over here. So that may be in keeping with erosions, but is there joint space narrowing or widening? I'm not sure. You're not seeing obvious widening like you're seeing at this location. It looks fairly parallel, even allowing for the erosive changes. So you could call this grade 2. So this one, you could say grade 2 to 3 sacroiliitis bilaterally. Here's another one. This is, again, fairly obvious, 39-year-old. You can see there's the sacroiliac joint is not seen whatsoever. So this is a grade 4 inflammatory sacroiliitis. Another patient, so this again, you can see very irregular looking joint. So there is alteration in joint space. Definitely, the joint space does not look equal at all at all areas. There is narrowing here, there is widening here. So all of these are erosive changes, and then you get to see the subchondral sclerosis on both sides of the joint as well. So this is a definite grade 3 sacroiliitis. Another one. So we'll come back to this case when we talk about the mimicker. So this looks like bilateral grade 3 with big erosions, widening of the joint space, and possible widening of the joint space inferiorly as well. We will come back to this case when we talk about the mimicker. So everything you see may not be an erosive change, but also you've got to take into account other factors that causes sclerosis as well. So when you're looking at an X-ray, don't be fooled by seeing focal areas of sclerosis and thinking that this is subchondral sclerosis related to the sacroiliitis. So here we're seeing a focus of subchondral sclerosis at the mid portion of the sacroiliac joint. But the rest of the sacroiliac joint doesn't look too bad at all. You can see the parallelism of the joint very well. You're not seeing much subchondral sclerosis elsewhere, not clearly identifying an erosive change as well. So luckily, this patient had a CT scan. And again, this is the area that we are interested in. So when you do a CT, you see this osteophyte. There is an anterior bridging osteophyte involving that sacroiliac joint. So that's what's showing up as sclerosis involving the sacroiliac joint. So if you're seeing a tiny focus of sclerosis at one portion with the rest of the sacroiliac joint appearing normal, think whether this is indeed an inflammatory sacroiliitis. Could this be osteophytes that are bridging the sacroiliac joint, fooling you to think that this is subchondral sclerosis? So we spoke about New York criteria. So in 1984, they modified the New York criteria by adding clinical criteria to it as well. So radiological criteria is unchanged. So we know the grade 0 to grade 4. But the clinical criteria are the clinical features of an inflammatory back pain. So low back pain and stiffness more than 3 months, improves with exercise, not relieved with rest, limitation of lumbar spine motion, and limitation of chest expansion due to inflammatory arthropathy affecting both the sternomanubrial, costochondral joints, but also at the back, the costovertebral joints as well. So they are looking for those. So in order to make a definite diagnosis of ankylosing spondylitis based on the modified New York criteria, you want a positive radiological criterion, which we'll discuss what a positive radiological criteria is, with at least one clinical finding. So you need to have a clinical finding as well. So that is where radiology and clinical picture blend together. So having a radiological finding, especially in the previous case, we thought, without knowing the clinical history, you can't make a definite diagnosis of an inflammatory sacroiliitis. So that's where the clinical side comes in. So what is the radiological criteria needed to make a diagnosis of ankylosing spondylitis? You need at least one clinical criteria. So according to the modified New York criteria, if you're talking bilaterally, it needs to be at least grade 2. So you want at least grade 2 sacroiliitis bilaterally. But if the patient has only unilateral sacroiliitis, you need to push it one further. So it's either grade 3 or grade 4 unilaterally. So grade 2 bilaterally at least, or grade 3 or 4 unilaterally. So that you need that level of positivity to make a radiological criteria diagnosis of ankylosing spondylitis. But still, you need the clinical picture to make a complete diagnosis of ankylosing spondylitis. We can give our radiological criterion, but they may not have ankylosing spondylitis at all if they do not fit the clinical picture. So that's where you need to marry both together, the clinical and the radiological side, to make a diagnosis. But again, the problem with X-ray diagnosis of sacroiliitis, including grading of sacroiliitis, is variability. It's a very subjective scoring system. Between us radiologists, we can have different scores for the same patient. And even in the same radiologist, I may score one differently at different times during the day or different days of the week. So the variability has been shown in multiple studies that the inter-observer as well as intra-observer variability is high. So that is the problem with X-ray diagnosis of an inflammatory sacroiliitis. Okay, so what about sacroiliac joint MRI? So we've said that X-ray is great, but there is that time lag of about at least 5 to 7 years before you see radiological findings of an inflammatory sacroiliitis. So that's where MR comes in. So this is our standard protocol that we use at our center for imaging of sacroiliac joints. So we do 2 sequences in 2 planes, so coronal oblique plane and an axial oblique plane. So the obliquity has to be in plane with the sacroiliac joint. So the sacrum is tilted anteriorly, so the coronal oblique and the axial oblique have to be tilted along the plane of the sacrum as well. So you do a coronal, a T1 and a fat sensitive sequence. So STIR is better because you get uniform fat suppression and homogeneity of fat suppression rather than using a T2 fat sat sequence. So here we are looking for sensitivity to pick up edema. So you don't want any fat inhomogeneity. So stir is always better than chemical suppressed fat saturation like a T2 FSE fat sat. And the other thing that we include with sacroiliac joints are these two Dixon images. So a lot of studies have shown that you need an erosion-specific sequence as well. The T1 sequences are not great at picking up erosions. So that's why you use an erosion-specific sequence. And T1 Vibe Dixon is a great sequence to look for erosion. So here you can see the contrast between the articular cartilage and the subchondral bone plate. So you can very easily identify any erosions that may be there by using these sequences. So the T1 Vibe Dixon, also known as the 4-point Dixon. So there's a water only, fat only, in phase and out of phase sequences, and they can be done within 30 seconds. So they're a really good addition to increase your confidence in diagnosis of erosions within inflammatory sacroiliitis. So again, similar to the X-ray, what you're looking for is a subchondral bone plate or the articular cortex. Here you see it as in X-ray, you'll obviously see it as a white line. Here you see it as a black line because of the cortical bone. So again, that is what you want to look for in MRI. Here is again on CT that you can see the subchondral bone plate very nicely as well. So that is what you want to follow across the sacroiliac joints bilaterally. So osteitis or edema. So this is the one criteria that you use to make a diagnosis of an active inflammatory sacroiliitis. So you're looking for periarticular high signal on whatever fat saturated sequence you use. So it'll be low to intermediate on T1 and high signal on T2 weighted imaging. And it usually occurs on the iliac side of the joint. Why? Because the iliac side cartilage of the sacroiliac joint is much thinner than the sacral side of the cartilage. So that gets attacked quicker than the sacral side. So you tend to get subchondral marrow edema more on the iliac side of the joint. So here you can see low signal on T1 and increased signal on T2 weighted imaging. Another case, you can see much more prominent inflammatory edema involving both the sacral and iliac side of the joint. So, and also T1, you get more marrow replacement, so lower signal than the fatty marrow corresponding to the areas of marrow edema. Now, erosions can also be seen with MRI. So here you're looking for articular surface irregularity and a break in that subchondral bone plate. So again, very similar to how the iliac side of the joint is affected, erosions tend to affect the iliac side of the joint as well, because the cartilage is thinner, and so the subchondral bone plate is less protected on the iliac side of the joint. So again, but erosions, as I said, can be better evaluated on the T1, the Vibe Dixon sequences, the erosion specific sequences, but CT is way more better than MR in diagnosis of erosions. But unfortunately, we can't use CT for diagnosis of erosions. So again, here are some other examples of erosive changes. You're looking for this irregularity of the subchondral bone plate and looking for erosions. Again, this patient has associated marrow edema as well. So to make it clear, only marrow edema can make a diagnosis of an active inflammatory sacroiliitis. Everything else only says that this patient has had inflammatory sacroiliitis. It does not say whether the patient is actively inflamed at the moment. So again, you can see these erosions on the corresponding radiograph of this patient as well. Here is another patient with multiple erosions. You can see undulating erosive changes involving the sacroiliac joints, corresponding X-ray here. You can see these erosive changes over here as well. And this patient had a CT as well, and you can see all these erosive changes on both sides of the sacroiliac joints. And chronic erosions obviously will look similar to the erosions, but you wouldn't get any marrow edema associated with it. So that means that there is no active inflammatory change going on. This is sort of chronic structural changes. You can see the erosions on T1 as well as on STIR images as well. Now, fatty metaplasia is another thing that you would see in chronic inflammatory sacroiliitis. It's also known as post-inflammatory fat accentuation. Periarticular, and because it's fat, it will follow the fat signal, so high on T1, low on T2 fat suppression. Be careful. If you are only looking at that T2 fat sat or a stir image, make sure that you do not call this subchondral sclerosis. So look at the corresponding T1 as well. So obviously subchondral sclerosis, which I'm going to show you next, will have low signal on both T1 and stir, whereas fatty metaplasia will be bright on T1 and dark on stir images. So always look at both sets of images before you call it either subchondral sclerosis or fatty metaplasia. And you can see subchondral sclerosis and fatty metaplasia coexisting as well. And usually it is deep to the subchondral bone plate. So it sort of comes up to the subchondral bone plate and goes further out. And the depth can be more than 5 millimeters. And it's more dense closer to the joint and gets lesser dense as it goes away from the joint, which is fairly obvious. And then what happens over time is repeated inflammation, and the inflammation settles down. Then the body deposits more bone into those erosive changes and the articular cavity. And then you get backfill and ankylosis of the sacroiliac joint. So then the sacroiliac joint ceases to exist. Again, when you get to this stage, you hardly will see any marrow edema associated with it because this is all burnt out inflammatory sacroiliitis. Another case of backfill ankylosis. So when you get backfill before you get to ankylosis, it will look like sclerotic bone. It won't look like the normal subchondral bone, and that is sort of infilling of bone in previous or old erosive changes. So chronic sacroiliitis, all you're going to see is erosive changes, subchondral sclerosis or fatty metaplasia, but no marrow edema whatsoever. So when you're doing an MR for an inflammatory sacroiliitis, the rheumatologist, all they want to know is there active inflammatory change? So only thing you're looking for is their marrow edema. So that is the only thing that you want to evaluate when you're looking for a sacroiliitis. Now, everything, I could stop this talk here if there weren't any differential diagnosis. But unfortunately, the differential diagnoses are what causes problems in diagnosis of inflammatory sacroiliitis, and none better than osteoarthritis. Now, 68% of asymptomatic patients older than 50 years showed degeneration in at least one SI joint at CT. So whenever you're dealing with somebody over 50, and when we do a lot of sacroiliac joints, we can see that even 50 is probably a higher limit. We can bring it down to 40 as well. So anybody over 40, if I am reading an MRI of the sacroiliac joints, my default is this is degenerative change until proven otherwise. So the MR has to convince me that this is not degenerative change, because degenerative change is so popular when we get to 40, 50 and above. And so what are you looking for in osteoarthritis? So osteophytes, the classic features, sclerosis, joint space narrowing. So this was a study that was done in a while ago, in 2010. So they looked at patients with low back pain at varying ages, so 18 to 60. And 100 patients, so 1/3 had SI joint abnormalities, and the vast majority of them had degenerative changes. So degenerative changes statistically is way more popular or way more common than inflammatory sacroiliitis. So be careful when you diagnose sacroiliac joint sacroiliitis. Make sure it's not degenerative. So degenerative change is more predominantly found in women, at least in this study as well. So how can you make a distinction? One is age, as I said. And bone marrow edema related to degenerative joint disease is very thin, and it's very focally located adjacent to the sacroiliac joint, whereas the MR edema due to inflammatory sacroiliitis that I showed earlier, it expands way more outside the confines of the joint. And the marrow edema is often less well-defined in inflammatory spondyloarthritis, whereas the marrow edema due to degenerative joint disease is very focal and very limited to that location. And if you have erosions, it's usually it's a spondyloarthropathy, because you should not be getting erosive changes in osteoarthritis. And location. So mechanical mechanical or degenerative changes, they occur in the antero-superior aspects of the sacroiliac joint. So when you're looking at the coronal slices, if you see abnormality within the first 2 or 3 anterior slices, it most likely is osteoarthritis rather than an inflammatory sacroiliitis. And inflammatory sacroiliitis, as I said, it tends to prefer the synovial joints, which are much more prominent inferiorly. So you would get, it is in the antero-inferior aspects rather than the anterior aspect. So the antero-superior. So if you're scrolling from anterior to posterior on a coronal image, the first 2 to 3 anterior slices favor a degenerative arthropathy. And this is another one that I want to show is osteitis condensans ciliae. This is another differential diagnosis that you would come across. The pathophysiology is not really understood. You see it commonly in women who've been pregnant and given birth, but you can also see in men and women who have not given birth. But most of the time, it will be seen in women who have given birth, in the not too distant past. Clinically, you cannot differentiate. The clinicians are often not able to distinguish between osteitis condensans ciliae and inflammatory sacroiliitis. By virtue of its name, it tends to affect the iliac side of the joint. The other thing is, look at the joint itself. You're still seeing the parallelism of the joint. The joint itself is not affected. You're seeing a ton of subchondral sclerosis. That's all you are seeing. And it tends to affect the inferior aspects of the bone and bilateral in vast majority of cases as well. And over time, they can resolve. They will resolve after the stress of pregnancy and everything is over. It can tend to resolve and reverse itself. But CT has shown that the sacral bone is also sometimes involved in osteitis condensans ciliae. But for the purposes of definition, if there is sclerosis, it'll be more prominent on the iliac side, and only a very small amount will be seen on the sacral side of the joint. Now, I'll skip through these in interest of time, but the one other thing that I want to chat about is insufficiency fracture. Obviously, do not forget about fractures as well, but then they will have characteristic appearance on CT. You're looking for linearity, sclerosis, and you should not see any erosive changes within the joint. And obviously, the iliac side of the bone should not be involved either. The other one I wanted to chat about, not to miss, is septic arthritis. And the teaching is that if you see a unilateral sacroiliitis in someone who does not have a history of inflammatory spondyloarthropathy, you want to rule out septic arthritis. Septic arthritis should be of primary concern. So here is an MRI of patient. The left sacroiliac joint looks completely normal. There is a lot of marrow edema, erosive changes, joint space widening as well. How do you distinguish between an inflammatory sacroiliitis and septic arthritis? Obviously, clinical history is useful. Blood markers, are they septic? And also the edema and contrast enhancement will extend into the soft tissues outside the bone. Inflammatory sacroiliitis is very much localized to the joint itself. You will not see any periarticular edema or any periarticular inflammatory change whatsoever. If you see periarticular inflammatory change, edema, enhancement, think about septic arthritis because inflammatory sacroiliitis will not do that. And obviously, if you see abscesses, then that is easy to diagnose. And usually it tends to be unilateral. Very, very unusual to get bilateral inflammatory sacroiliitis. And even getting inflammatory and septic arthritis of the sacroiliac joints is unusual. Usually seen in patients who are immunosuppressed. And you're looking for extensive marrow edema and osseous destruction. And osseous destruction, you can see it's very much better seen on CT. Here is a patient, and you can see the sequestrum within the joint, marked widening of the sacroiliac joint as well. And as I said, the two differentiating features that you need to be aware of when you are dealing with septic arthritis is obviously the capsulitis is much thicker in septic arthritis compared to inflammatory sacroiliitis. It'll spread beyond the margins of the articular surface and also surrounding edema. So periarticular muscle edema. If there is soft tissue edema that extends beyond the margins of the joint, this is not inflammatory sacroiliitis. Inflammatory sacroiliitis will never, ever cause edema in the muscles surrounding to it, or enhancement in the muscles surrounding. So that is definitely pointing towards an inflammatory, a septic arthritis rather than an inflammatory sacroiliitis. So that was a quick run through about an approach to sacroiliitis. Obviously, be aware of the New York criteria and the modified New York criteria. And obviously, where everyone gets fooled is the differential diagnosis, is what mimics as an inflammatory sacroiliitis. So look for secondary findings. Are we seeing osteophytes? Are you seeing fractures? Is there malalignment of the pelvis to result in changes in the sacroiliac joint? Look for distribution of edema on MRI, particularly distinguish between inflammatory and septic arthritis. And clinical history is very, very useful. You want to know the patient's HLA-B27 status. Age, very important. As I said, anybody 50 or over, you have to think this is degenerative, and that I have to be proven wrong that this is not degenerative. And past medical history is very useful as well. And as I said, SI joint inflammation and spondyloarthropathy, it's limited to the bone and the joint space, and will not cross anatomic borders to spread into the adjacent soft tissues. If that's the case, think about another cause as well. So that was a quick run through of approach to